Now we'll talk about the life cycle of red blood cells. Where are red blood cells made? Red blood cells are made in the bone marrow. So you can consider the bone marrow the factory where we make red blood cells. And the very, very original red blood cell is this big blue nucleated cell known as erythroblast. Erythro means red. Blast means large cell. Erythroblast. So if you compare this erythroblast with the mature red blood cell here, there are many differences. Probably the most important one, the erythroblast is nucleated. The red blood cell has no nucleus. So this nucleus of the erythroblast, which has nucleic acid, has to mature, has to disappear in order for this baby, young erythroblast to become mature red blood cell. You need this nucleus to mature and disappear. And any nuclear matter in any cell in the body needs B12 and folic acid to mature. So these two factors, in presence of B12 and folic acid, this nuclear matter of the immature erythroblast will start to shrink and eventually disappear to become non-nucleated red blood cell. The other major difference, and therefore the cell becomes smaller, by the way, because after disappearance of the nuclear matter. The other difference is the erythroblast is blue and the mature red blood cell is red. Why red? This is the color of hemoglobin with an iron molecule. So we need to fill this erythroblast with hemoglobin. And a major constituent of hemoglobin is iron. That's the chemical symbol for iron. So if you have enough iron, you can fill this erythroblast with enough hemoglobin to become the mature red blood cell. So it takes between 5 to 7 days for this immature erythroblast to become baby red blood cell. So this baby RBC, of course, we do not call it baby RBC, but we call it reticulocyte. So the product of the bone marrow, when the bone marrow gives birth to a baby red blood cell, it's called reticulocyte. And the reticulocyte resemble the red blood cell, but if you look closer under the microscope, you can identify some remnants of nucleic acid in the reticulocyte, and these remnants disappear in a couple of days. So in a couple of days, the reticulocyte becomes a mature red blood cell. But the reticulocyte count is very important, because if you have normally functioning bone marrow, you will have normal reticulocyte count. And how do we count the reticulocyte? We count them as a percentage to the red blood cell. So normally the normal count of reticulocytes is 1 to 2%. So out of the 5 million red blood cells, we should have no more than 2% reticulocytes, baby red blood cells. If the bone marrow is hypo-functioning, then the reticulocytic count will be low, less than 1%. If the bone marrow is hyper-functioning, then the reticulocytic count will be high. If the bone marrow is hypo-functioning and producing less number of reticulocytes, this means you will have less number of red blood cells. This means you have anemia for whatever reason. And when you start giving treatment for this anemia, whether it is iron deficiency or B12 deficiency or whatever, the bone marrow will start to work better and the reticulocytic count will start getting higher and higher. So this means the reticulocytic count has important diagnostic and prognostic value. Diagnostic value because it tells you, is your bone marrow normally functioning or hypo-functioning or hyper-functioning, and a prognostic value because whenever your bone marrow is hypo-functioning because you're lacking iron or you're lacking B12 or you're lacking folic acid and your bone marrow is not making enough number of red blood cells because of these factors deficiency, once you start treatment, the reticulocyte count will start getting higher and it serves a prognostic value. So this is the importance of the reticulocytic count. Then this mature red blood cell will keep functioning for 120 days, carrying oxygen, delivering oxygen to tissues. And as it gets older, when it exceeds 120 days, the macrophages in the spleen will recognize these aging red blood cells and will engulf them, will phagocytose them, and will digest them, will process what is inside. So what is inside red blood cells? Nothing but hemoglobin. And what is hemoglobin? The globin part, the protein part, will be metabolized to amino acids, and the heme has iron atom and the colored heme molecule. The iron is recycled. Our bodies are very efficient in recycling iron. We don't pee iron, we don't poop iron, we don't lose iron unless we bleed. Otherwise, the iron that is in the body is recycled. So this iron is going to be carried by a plasma protein known as transferrin and will be taken back to the bone marrow to share in the production of more red blood cells. And if you have excess iron, this iron will go to the liver to be stored in the liver as ferritin. So that's iron. What happens to the heme molecule? The heme molecule is metabolized in the spleen into biliverdin, and then this biliverdin is metabolized into bilirubin, And this bilirubin is called indirect bilirubin. So the product of heme metabolism is indirect bilirubin. So we say the product of red blood cell metabolism is indirect bilirubin. If you destroy more numbers of red blood cells, the indirect bilirubin will get higher. If red blood cells die younger than 120 days, so if you have hemolysis, if your red blood cells are destroyed inside the body, how do we know this? Whenever the indirect bilirubin goes up, we know that there is a lot of hemolysis taking place. So we call this indirect bilirubin, we call it a hemolysis marker. We call it a hemolysis marker because it tells us that red blood cells are being destroyed excessively, and that's why we have a lot of indirect bilirubin. This indirect bilirubin is water insoluble. And any substance in the body that is insoluble constitutes a potential problem because the kidney cannot get rid of it and it's going to accumulate in the blood, causing some problems. And indirect bilirubin is harmful to the brain. So we have to convert it to soluble substance. And this will be the role of the liver. So the indirect bilirubin will be carried by the plasma protein albumin and taken to the liver. And the liver will convert it from being indirect insoluble bilirubin into direct soluble bilirubin. And this direct soluble bilirubin will be stored in the gallbladder first, and then will pass with bile to the gut, and you get rid of it. Either you poop it or the majority of it gets reabsorbed back from the intestines, and it goes to the liver, again through the portal vein, and then to the systemic circulation as urobilinogen, and we pee it. So this is the life story of red blood cells. Now, there are two major mechanisms for anemia to develop. Two major mechanisms, two big categories of pathophysiology, and they can result in anemia. And they are described and explained in this slide. The first big category of anemia is what we call hypoproliferative anemia. Hypoproliferative anemia, which means the bone marrow is not producing enough red blood cells. So the major problem in hypoproliferative anemia, low production. That's the first big category. The second category is increased destruction of red blood cells. Increased destruction of red blood cells. What do we call this? We call it hemolysis. So what happens when you destroy red blood cells excessively? You're going to get anemic. And when you get anemic, which organ will freak out? Your kidneys. And when your kidneys freak out because you are anemic, what do? They produce excessive amounts of erythropoietin hormone. And what's the function of this erythropoietin hormone? It stimulates your bone marrow. So people with hemolytic anemia, their bone marrow is working overtime. Their bone marrow is hyperproliferative, and hence the name for this increased destruction, hemolytic anemias, we call it hyperproliferative anemia. So these are the two big categories, pathophysiologic categories of anemia. Let me use black color. The first category of anemia, hypoproliferative anemia, the bone marrow is hypofunctioning, and the second big category, hyperproliferative anemia. So let's talk more about the causes of these two types of anemia and how we diagnose them. Hypoproliferative anemia. What makes your bone marrow hypofunctioning? If you have renal disease, and your kidney is unable to produce erythropoietin, your bone marrow will be hypofunctioning. And we can see this in cases of chronic kidney disease. All patients with chronic kidney disease or chronic renal failure, they have anemia. And what type of anemia is that? Hypoproliferative anemia, because the bone marrow is kind of lazy due to the deficiency of erythropoietin hormone because the kidney is failing. That's the first cause. The second is, what are the ingredients, what are the nutrients that the bone marrow needs in order to produce red blood cells? For nuclear maturation, the bone marrow needs B12 and folate. If you have B12 or folate deficiency, the bone marrow will be unable to proliferate and manufacture red blood cells. So B12 deficiency, folate deficiency will result in hypoproliferative anemia. Also, the bone marrow needs iron to make hemoglobin, to fill this erythroblast with hemoglobin. Iron is a major constituent of hemoglobin. So if you have iron deficiency, then your bone marrow will not produce enough red blood cells and your bone marrow will be hypofunctioning. Or any cause of bone marrow dysfunction. If the bone marrow is destroyed by certain medications, destroy the cells of bone marrow, or by malignancy, bone marrow dysfunction for whatever reason. All these are the causes of hypoproliferative anemia. The most common clinical causes are iron deficiency, B12 deficiency, folate deficiency, and chronic kidney disease. Iron deficiency, B12 deficiency, folate deficiency, chronic kidney disease result in decreased production of red blood cells, hypoproliferative anemia. How do we diagnose it? low retics. Low retics. This is very important because what is the product of the bone marrow? It is the reticulocytes. So if the reticulocytic count is low, less than 1%, we know that the bone marrow is hypofunctioning. And by the way, when you start treating hypoproliferative anemia, if you have iron deficiency, when you start treating this patient with iron, the first thing that improves is the reticulocytic count. It starts getting higher and higher. The second category of anemia is hyperproliferative. Here, the problem is not in the bone marrow. The problem is outside the bone marrow. The bone marrow actually here, because it is stimulated by erythropoietin that comes out of the kidneys that are freaking out because there is anemia, the bone marrow is hyperproliferative. And how do we know that the bone marrow is hyperproliferative? High retics. So the first step in diagnosing hyperproliferative anemia, look at the reticulocytic count. If the reticulocytic count is high, you know that your bone marrow is hyperfunctioning. So how come the bone marrow is hyperfunctioning and producing big amounts of high retics of reticulocytes that will become red blood cells, and you have anemia? These red blood cells must have been destroyed outside the bone marrow. You must be hemolyzing. What's the difference between hemorrhage and hemolysis? Hemorrhage, you lose red blood cells to the outside of the body. You lose blood to the outside of the body. Hemolysis, you lose red blood cells inside your body. You destroy red blood cells inside your body. So in hyperproliferative anemia, you have high retics, but you should always look for evidence of hemolysis. So you should always look for biochemical markers of heme catabolism. And what is the most important biochemical marker of hemolysis? It is elevated indirect bilirubin. Elevated indirect bilirubin. So this is the most important marker that there is excessive hemolysis. What else is inside the red blood cell that can come out excessively when there is excessive hemolysis? An enzyme known as lactate dehydrogenase, LDH. LDH. So LDH goes up. So the hemolytic markers or the biochemical markers of hemolysis are increased indirect bilirubin, increased LDH. Now, when red blood cells are hemolyzed, before this hemoglobin is digested, some of the hemoglobin can escape and go to the circulation. Usually hemolysis occurs in the spleen. So as hemoglobin gets out of red blood cells, some of it can reach the circulation. And hemoglobin is not allowed to be freely moving in the blood. It should always be within the cell membrane of the red blood cell. And there is special plasma protein that is specialized in capturing any free hemoglobin circulating in the blood, and it captures it and it carries it back to the bone marrow to be utilized in making more red blood cells. This protein is known as haptoglobin. And when this haptoglobin is consumed in capturing the free hemoglobin, this haptoglobin gets low. It's like taxi cabs waiting outside Broadway theaters, waiting for people coming out of the theater to take them back home. So when you have big numbers of people coming out of theaters, the number of the yellow cabs, the taxi cabs will go low. So when you have big amounts of free hemoglobin in the blood, the haptoglobin will go low. So let me use the whiteboard to list for you the 3 biochemical markers of hemolysis. The 3 biochemical markers of hemolysis. The 3 biochemical markers of hemolysis. The most important is elevated indirect bilirubin. The second is elevated LDH. The third is low haptoglobin. Okay, so the two pathophysiologic categories of anemia are hypoproliferative anemia. The problem here is low production, and hyperproliferative anemia. The major problem here is increased destruction. Give me examples of hypoproliferative anemias. Deficiency anemias. Iron deficiency, B12 deficiency, folate deficiency, or erythropoietin deficiency. Give me examples of hyperproliferative anemias, hemolytic anemias. Diagnosis of hypoproliferative anemia. Of course, all anemias, low H and H. But hypoproliferative, you have low retics. Hyperproliferative, what do you need to diagnose hyperproliferative? Again, it's anemia, so it's low H and H, but there is high retics plus evidence of hemolysis. You have the three biochemical markers of hemolysis. So to diagnose hemolytic anemias, to diagnose hyperproliferative anemias, you need to have high retics and the three biochemical markers of hemolysis. High retics and the three biochemical markers of hemolysis. Increased indirect bilirubin, increased LDH, and low haptoglobin. In the next segment, we're going to talk about hemolytic anemias in more details.